We are still talking about the drugs used to suppress inflammatory and immune reactions. First, we discussed the NSAIDs. We are now talking about the drugs that are used in the management of gout. First, what is gout? Gout is an inflammatory arthritis. Okay, you can see arthritis, there is a inflammation of the joints, and it is caused by the deposition of monosodium urate crystals in articular joints. And the way it manifests is it manifests as an acute attack, like it just starts. Okay, it just starts and then someone is having pain on the joints. The chronic gout with formation of tophi occurs after years of acute intermittent gout. Something that is chronic takes a bit time. The treatment of gout involves the management of the acute attack and also long-term management. Because if let's say for example, someone has come to the hospital now, they are failing to breathe. Before you can start thinking about stopping what is making them, stopping really the big condition is first help them at that particular time for them to breathe. So that's the same way. Someone has come with an acute attack. First, help them with that acute attack so that they can be relieved as you look for a permanent solution for what might cause that. So these are the uric acid crystals. You can see they get to be deposited on the joint, and so there is inflammation. You can see redness, swelling there. Okay. So how does gout come about? The pathophysiology. You have got a breakdown of purines, you should remember from our biochemistry. When purines are broken down, you are forming this xanthine. Using xanthine oxidase, you are going to convert xanthine to urate. And then this urate now can be the one that will go to the kidney to be excreted. Sometimes the urate will just be there and it is asymptomatic. So that's asymptomatic hyperuricemia. You just have a lot of it and then there's no symptoms. Okay. So on the treatment of gout, these are the stages basically that are going to be involved. To stop the xanthine from being converted to urate, you can block the enzyme xanthine oxidase using the drugs allopurinol and febio, this febiostat. And then when you already have the urate, if you want to prevent it from going to the kidney, okay, because it can actually not to prevent, because urate is removed from the body via the kidney. So since it's a lot in the body, you want to remove a lot of it. So you can give the drug probenicid. It will promote the excretion of urate. So that is what happens. And when you have got this urate, the monosodium urate, they are going to be deposited in joints. Okay. So NSAIDs, in that case, just so before then, the monosodium urate in the joints, they can as well, of course, end up going in soft tissue and also in the joints that causes what we call tophi. So this monosodium urate, they can get to lead to inflammation. So we're going to have inflammatory cells coming. You can see there's destruction of the tissue here. Okay, so there's inflammation. So you can have drugs that you can give at this point to inhibit the inflammation. Drugs like NSAIDs, colchicine, the glucocorticoids. Glucocorticoids work like NSAIDs, just that these are much broad. So what is the rationale for the management of acute gout? What do we want to achieve? Or what are we trying to aim at in treating gout, acute gout. So you want to do symptomatic management, like you want to help with the symptoms that the patient is presenting with. So you are going to give high doses of NSAIDs unless you can't give them, they are contraindicated. Okay. You can also give coaching or low dose oral steroids. These are the glucocorticoids we are mentioning. These are others that you can give, but these ones for short-term use in patients on oral anticoagulants. You know why? You don't give NSAIDs to someone that is taking anticoagulants because NSAIDs promote bleeding. Anticoagulants are stopping bleeding. So if someone is taking anticoagulants, you give them coxine or the steroids, the glucocorticoids. They help in the inflammatory process. So coxine does not cause fluid retention, and so it is preferred to NSAIDs in chronic heart failure. So imagine someone has got gout. They also have chronic renal failure. One symptom of renal failure is that there's going to be retention of fluid. There's a lot of fluid, and then it can end up going also to the, for example, the left side of the heart is failing. The heart will not be able to pump blood to the rest of the body, so the blood will start going back to the lungs, and then it will start going out of these capillaries in the lungs, and that is going to cause pulmonary edema. So coxine is better in that it does not cause retention of fluid. The NSAIDs, when you give them, of course, they'll help you with the pain, but then they cause this retention of fluid. And what that is doing is that you are having a lot of fluid in the body, and that is going to worsen chronic heart failure. So, what is the detailed now? The detailed management of acute gout. Acute attack of gout is very painful, and effective anti-inflammatory drugs should be used immediately because of the pain. So I've got NSAIDs or COX-2 inhibitors like naproxen, diclofenac, etoricoxib. So just the COX-2 inhibitors, the NSAIDs, you give them in maximum doses. Like you give a very high dose, then you taper down 24 hours after symptom resolution. So you give a very high dose, and then as when the symptoms resolve, you start now reducing the doses a bit by bit. Okay. These drugs, however, the NSAID should be avoided if someone has got renal disease, heart failure, and those on oral anticoagulants or with peptic ulcer disease. Why? In renal disease and heart failure, there is fluid retention. NSAIDs also causes fluid retention. Actually, one feature of renal disease, for example, if someone has got nephrotic syndrome, if they wake up early in the morning, they'll tell you that they have got swollen eyes. We call it periorbital edema. Someone that has got renal disease, like nephrotic syndrome, and also heart failure, they'll present with things like ascites. Okay, the abdomen is full of fluid, it has got a lot of fluid. And when you come to the ward, we just going to inject a needle and then start draining the fluid. Just last week, there was a woman that came and we drained from her 8 liters of fluid, and the stomach, the belly was still so big. That is how much fluid she had. Okay, it's a lot. That's because if the heart is failing or the kidney is failing, there's this retention of fluid, and then this fluid will start going into these interstitial spaces. Someone on anticoagulants, NSAIDs, actually inhibit platelets. So you don't want to give them because someone is on anticoagulants, the platelets will not be able to work. Okay, that those that prevent bleeding. And then for someone that has got peptic ulcer disease, again, the NSAs promote bleeding. Peptic ulcer, someone is also bleeding, so that becomes a problem. Coxine is used in acute gout and to recover the introduction of allopurino. Okay, sorry, to cover the introduction of allopurino. Remember, allopurino is another drug that you'd give that is inhibiting xanthine oxidase. Okay. Diarrhea, nausea, abdominal pain, these are the side effects of this drug. And nearly every drug has got, if there is something that you not go around, they say give a side effect of a drug is nausea and vomiting. Nausea, vomiting. And this one also has diarrhea and abdominal pain. Low dose oral steroids, for example, prednisolone, you give 7.5 milligrams per day for 3 days, or intraarticular steroids, like the one you just inject on the joint where there is pain. Okay, so the intra-articular steroid to an affected joint after infection is going to be excluded. So someone has got an infection, you don't want to give these intra-articular steroids, but you can give steroids like prednisolone for 3 days. So that was for acute management. You want to relieve of the pain that someone is feeling at that given time. How about long-term gout management? So chronic management of gout aims to reduce uric acid formation by the use of xanthine oxidase inhibitor. So you can give allopurinol, which should not be initiated, okay, which should not be initiated or stopped during an acute attack. The alternative to allopurinol are uricosuric drugs and the newer xanthine oxidase inhibitor febuxostat. So febuxostat works like allopurinol, but you can also give these uricosuric drugs, the ones that will promote urination, like progenicid. All right. But allopurinol should not be initiated or stopped during an acute attack. If someone has got an acute attack, you don't give this drug, or you don't stop if someone has got simple. You are trying to manage a long-term condition, and then someone has got an acute attack. Like acute means that it goes a bit beyond normal, and then they just at that point it is so worse. You don't stop the drug. Okay, it's used for long-term management. So about what's happening acutely, don't worry about it. Other things that we want to advise the patient is lifestyle changes where possible. Okay, the avoidance of diuretics also. Diuretics are drugs that cause the loss of fluid. So you as well want to avoid these drugs. If you are losing so much fluid, you end up precipitating the condition, becoming worse. Imagine you just end up removing fluid and then you are remaining with the crystals. Okay. You can as well give losartan and the fenofibrate. These ones have urate lowering properties. They should be used preferentially in appropriate comorbidity. If someone has got some other conditions like losartan, if someone, let's say they are having things like heart failure. Lifestyle advice that you want to give: reduction of alcohol, dietary intake of purine, and obesity management. Yes, please. Yes, this is going to be worsening it. So I want to help the patient by advising them to reduce on that. Also, the dietary intake. Remember the purines. Okay, so it's the breakdown of these purines that is actually leading to all the problems here. So you want to restrict the intake of purines and also manage obesity. Okay. The pharmacological management, when we are giving drugs, aims in the aim is reduction of serum uric acid levels. Number one is by inhibition of uric acid formation by inhibiting this xanthine oxidase and also promoting the excretion of urate in urine. Again, this is the steps how the metabolism of nucleic acids. The purines will first form hypoxanthine. Hypoxanthine will form xanthine using the enzyme xanthine oxidase. Xanthine will form uric acid using xanthine oxidase again. So allopurinol and febuxos- febuxostat inhibits xanthine oxidase. Uric acid is supposed to go to the kidney to be excreted, so you can give probenecid to promote the excretion of this drug, or sulfamyrazole. Again, uric acid can be converted into allantoin, which is water soluble metabolite. So this guy can dissolve in water. So the enzyme here that is needed is urate oxidase. So you can give as well a drug, lasburicase, that to promote the conversion of uric acid to allantoin that can dissolve in water. Because uric acid itself causes problem because it forms crystals, and those crystals get deposited on the joint, and that is what causes the problem. So xanthine oxidase inhibition, again we've said it's via allopurinol and also the febuxostat. Allopurinol, the pharmacokinetics is well absorbed from the GI tract, so you can give it orally and it is rapidly cleared from the plasma. It has got a half-life of 2 to 3 hours. That's the period in which it's going to work. It's converted to alloxanthine, okay, which by this alloxanthine is a xanthine oxidase inhibitor. It's the one that inhibits xanthine oxidase, which, okay, and when it's converted to alloxanthine, it inhibits the metabolism of the parent drug. So when you get allopurinol, you give it, it will be converted to alloxanthine. This alloxanthine will be stopping the breakdown of allopurinol, and that means that it will now be able to work more because it's there. Adverse effects are unknown. Hypersensitivity reactions can happen, like skin rash accompanied by fever, malaise, muscle pain, and also rarely blood dyscariasis, like blood disorders, okay, like things like anemias, those things. However, these ones will resolve once you stop using the drug. And the dose reduction to a maximum of 100 milligrams per day is required if someone has got renal failure. Drugs depending on xanthine oxidase for their metabolic conversion must be used with caution. Okay, for example, 6-mercaptopurine and azathioprine. So these drugs, for you to convert them, to break them down, you need xanthine oxidase. But the thing is that you've inhibited xanthine oxidase. So meaning that these drugs will just be there in the body, so they can actually lead to toxic effects. So you need to use them with caution. And the other thing is that allopurinol inhibits warfarin metabolism, the breakdown of warfarin. So you need to close monitor, okay, the anticoagulant control. So close monitoring of anticoagulant control is going to be important. So the thing is, you give allopurinol, warfarin is an anticoagulant together with heparin. So warfarin is stopping coagulation, and then you've given allopurinol that is stopping the breakdown of warfarin. So there's going to be too much anticoagulation. Okay, too much anticoagulation. So what do you think is going to happen? It can lead to excessive bleeding problems. Allopurinol must not be instituted during an acute attack of gout. Okay, it may be prolonged. So if you give allopurinol while someone has got an acute attack, it might take it, the acute attack can actually prolong instead of helping, because this drug is given for long-term management. Considered in patients who have experienced 2 or more acute attacks of gout in a year, and in those with the TOFI. So that's when you give allopurinol. If a patient has experienced 2 or more acute attacks of gout in a year, and those with TOFI, and it started 4 weeks after the acute attack has settled, and then you are going to titrate it up at a 4 weekly interval until the serum uric acid is adequately suppressed to be less than zero point 0.3. So you'll be after 4 weeks post the last attack, you start giving the drug. You start with a small dose and then you'll be increasing and increasing. The introduction and up titration of allopurinol should be considered by the concurrent administration of low dose NSAID or coxetine. Okay, you'll be giving this NSAID together with the allopurinol as you taper, as you increase the doses. You also have uricosolic drugs. Febuxostat, it does the same function like allopurinol, probenecid, and sulfimpirazone. These ones inhibit the tubular reabsorption of uric acid so to promote excretion. And they are useful where allopurinol is not tolerated or fails sufficiently to lower urate, like in patients with normal renal function. Okay. So if someone has got normal renal function, you want to give them this drug so that they can just promote excretion. But if someone has got compromised renal function, you don't want to give them prosenamide because the kidney is not working to promote excretion. Patients must be encouraged to maintain an adequate fluid intake to prevent crystallization in the urine. But the thing is that that's why we said you avoid diuretics, because if you are taking diuretics, you are losing a lot of water and then these crystals will end up forming. So that's why patients should take a lot of fluid. Another drug that can be given is benzibromarone. It is also uricosuric, which can be used in patients with mild renal impairment. They have got impaired renal function, but it's not that bad. It is restricted because of concern about hepatotoxicity, although the absolute risk is low. So that's a big problem. Hepatotoxic can cause injury to the liver. Rasburicase is a recombinant urate oxidase given by IV infusion, and it is used prophylactically for hyperuricemia in chemotherapy for hematological malignancy. So if you are treating someone that has got a cancer of the blood using chemotherapy, and then they have got hyperuricemia, you can now give this rasiburic and is given prophylactically. The meaning of that is you are giving it to stop hypercalcemia from happening. Prophylaxis is stopping something from happening before it happens. So that is basically it about drugs that we use in the management of gout. So you can see a question here. Following his third episode of gout arthritis, a 50-year-old man sees you in the clinic. Each case was successfully treated acutely. However, your patient is interested in trying to prevent the future episodes. He is not on regular medication and has a normal physical exam today. Blood work reveals an elevated serum uric acid level and otherwise normal renal function and electrolytes. A 24-hour urine collection for uric acid reveals that he is under excreting uric acid. Suspecting that this is the cause of his recurrent gout, you place him on probenecid. What is the mechanism of action of probenecid? Probenecid? What drug could have their excretion inhibited by probenecid? So let's start. What is the mechanism of action for probenecid? Okay, so it is uricosuric to prevent the reabsorption and increase the excretion. So part two is saying which drugs could have their excretion inhibited by probenecid. So other drugs whose secretion could be inhibited includes penicillin, endomethacin, methotrexate. So these drugs, the thing when you give probenecid, the only thing is that you are stopping the the reabsorption. So drugs that could have their excretion inhibited include those penicillin, indomethacin, methotrexate. So they'll still be in the body, you not excrete them, so they can lead to some adverse effects.